Hello, I'm Donal Macaulay, and welcome to this conversation on medicsvoices.com. Today I'm talking to Tara Kieran in Toronto. Tara, you have a fantastic job title. Tell me a little bit about it.
So I'm the Fidani Chair of Improvement and Innovation at the University of Toronto. And to me, what I love about my job, it gives me the freedom to think big about what it is that we need to do to really make our primary care system better and work for everyone.
So improvement and innovation, that's a very broad canvas. So tell me what kind of things you do.
Yeah, so I spent some of my time at the University of Toronto in really overseeing the quality and innovation program at our Department of Family and Community Medicine. So what do we do there? Well, we try and support our teams to be able to measure and improve quality of care. So for example, over the last few years, actually since COVID began, our teams have been, we have 14 family medicine teaching units in the Department of Family and Community Medicine, all varying in size and their location where they are. But now we all actually run the same patient experience survey, and we do it in the same way. And our department helps to actually coordinate all of that and analyze the results, give it back to the practices to make it easy for them to understand what they're doing when it comes to the type of care they're providing for patients and how they could do better. So patient experience is one kind of data that we work with. We also work with electronic medical record data and data from administrative sources that we try and give back to folks. Another big focus for us is actually capacity building. And so we want people to have the knowledge and skills for how to improve quality in their practice. So we do a lot of teaching of quality improvement, but we also do teaching more broadly in terms of continuing professional development. We're thinking about, how do people keep up to date on a long-term basis? We're starting to experiment with ideas of like peer-to-peer coaching as an example. And we've also started to do more forums for family doctors actually across our province. So when COVID began, we started hosting together with our partner, the Ontario College of Family Physicians, a bi-weekly virtual series called the COVID-19 Community Practice for Family Doctors. And every 2 weeks now, we have like anywhere from 600 to 1,000 family doctors join our webinars to learn about the latest in COVID. And actually, a big part of it is learning from each other. So it's become just really the safe space for people to share their own knowledge and gain knowledge from their peers.
Now, let me take it back a bit because I was interested. You have a lot of experience with Indigenous populations, and this is something that is particularly important in Canada. Tell me how that's influenced your own career.
Well, I'll just say that, trying to advance equity and close equity gaps has been a running theme in my career since it began. It started with me really trying to do that as a practicing clinician, and I worked at many community health centers in the inner city of Toronto that worked with more marginalized populations. I also worked in many remote and rural communities, including in reserves up in Northern Ontario, First Nations reserves in Northern Ontario, as well as Indigenous communities further afield. And I think that really shaped my own thinking in ways of kind of understanding health early on. And it led me to want to do more. And I ended up doing a master's in public health or MSc in public health that allowed me to expand, I guess, how it is that I may be able to understand the concepts of health equity and influence them. And so I acquired skills in health services research, and in the beginning of my research career, a lot of the work I did really documented inequities between groups. And moving forward, I'm trying to do more and more to go beyond just documenting the inequities, but of course trying to close them. And I will say, though, I've learned a lot myself over the last 10 years about how much I don't know about our own history in Canada when it comes to Indigenous people. When I think about the work I did with Indigenous people as a young clinician, I think about actually so much of my own ignorance in terms of the history and legacy of colonialism and how it shaped the health of the people that I was serving at that time. And since then, I've had the opportunity to do Indigenous cultural safety training, et cetera, that have changed the way that I understand the issues. And what I've learned also is that, for us to really address it, is it's about me being an ally and trying to amplify the voices of the Indigenous colleagues and populations that I work with and serve, and working with them to support them to be able to, have self-determination about the solutions that would work for their own communities.
So for clinicians listening to this, what is your message for them in terms of looking after the Indigenous communities?
I think it starts with unlearning and relearning what it is that you fundamentally think that you know, because chances are I think we all have biases that relate to how we learned about Indigenous people growing up, that some biases that are so deeply entrenched that we're not even aware of them. And so I think for clinicians, it's about unlearning and then learning about the history of Indigenous people and how that relates to the current state we're seeing now. Because I think it's very easy when we see an Indigenous patient. First of all, many of us may not even realize it's a patient who's Indigenous because they're maybe, for very good reasons, not wanting to disclose for fear of racism and discrimination. But even once we do know someone is Indigenous, how we treat that person is ultimately informed by our own biases, and the life circumstances of that person is informed by the colonial past of our country.
Now, you're a tremendous advocate for primary care in the widest sense, and I know you're concerned about the future of primary care and how we can strengthen primary care. Tell me a little bit about your work on how we can strengthen primary care.
So when I first became a researcher, a lot of the work I did was really trying to understand how reforms that have been enacted in the last decade have influenced the quality of care that is being provided. So for example, if you organize care differently, if you bring in teams, if you pay physicians differently, does that actually change the, whether people are getting the right treatments, the recommended care, whether they're going to the emergency department or getting sick? So trying to understand those questions, all with it, as we've talked about, the underlying premise that for health systems to work well, we need a strong primary care foundation. And that if we look across the world, we see variation in how strong those systems are, and that we can learn about how we can do better from other countries as well. And then as I've gotten further into my career, it's been not just doing research to understand kind of how we can do better from a policy perspective, but also trying to directly support clinicians and teams to do better from a practice perspective. And then most recently, I've been really interested in working with and hearing from members of the public about what their experiences are like in primary care and what their priorities, needs, values, and preferences are for the future. Because more and more I've come to recognize, of course, we have a terrible situation in Canada where not enough people have a family doctor. Our latest survey that we did this past fall pins it at about 22% of people in Canada 18 and over without a family doctor. That's more than 6.5 million. And in order for everyone for us to realize a vision of everyone having a family doctor, we need to start to have I think, a broad public dialogue about what that means and the trade-offs that might be involved, and the types of models that we might need. I think we need to start really thinking about things differently around how our systems are set up in order for us to be able to achieve that vision of everyone having a family doctor or nurse practitioner.
When you wrote in CMAJ, I noticed that you said training more family doctors is not the answer. What do you think the answer is?
Yeah, so I think there are many things that we need to do differently. One, we definitely need more teams. There's lots of evidence that team-based care, when done right, can improve patient outcomes. It can actually improve provider joy in work. And importantly, it can grow clinician capacity to see more patients. We do have some teams in Canada, and I'll say the way they've been implemented hasn't always been with that last objective in mind. But I do think we need to expand team-based care if we are going to really leverage the full potential of the family doctors and nurse practitioners that we have currently. Because I think there's logistically no way for us to train the number that we need in time for the population who needs care now. In addition to teams, I think we need payment reform. Teams work best when physicians, I think, are on salary or capitated models and not working in a fee-for-service setting. But I also think we need to really rethink how our systems are structured. Now, I actually, as a physician myself, benefit from a whole lot of autonomy, but I actually think we need to start to think about whether that autonomy is really good for the system. And we probably do need more physician accountability in the system and bring physicians in. Now, that could also come with benefits, though. We've also heard from new grads that many of the reasons they don't like to go into family medicine is because they have to set up their own business, and they have to figure out who to cover for them if they want to take a vacation or if they want to go on parental leave. But what if we started to have organizations that employed these doctors, gave them benefits, took care of the business part so that they could focus on the doctoring part? And what if we started to think differently about how we actually set up our systems so that it was more like a public school model where people didn't have to go on waiting lists and call around to try and find out whether there's a family doctor that's accepting them. If they move into a neighborhood, the local clinic that's been set up has to take them on. And that local clinic would provide regional after-hours care together with other clinics in the neighborhood. And you wouldn't need walk-in clinics. All those walk-in clinic physicians could be doing something different. They could be working in continuous longitudinal practices. So I'd love to see us really rethink what we're doing.
So in addition to the reorganization, which clearly you're very passionate about, what about the recruitment and engagement of young doctors with family medicine?
It's a really important point. Right now we have an issue where over the last decade, there's been a slow decline in the interest among medical students to choose family medicine as a specialty. And then even among the family medicine residents who do train, fewer of them are choosing to practice longitudinal continuity-based office care. So they're not opening up their own family practice or joining a family practice in the way we traditionally imagine, but they're using their family medicine training and doing other things, some of which are definitely needed in the system, like doing emergency medicine, but sometimes they're doing other things that arguably I'd say could be instead folded into a family practice, whether that be sports medicine, whether that be fertility medicine, whether that be even psychotherapy. All of those things are human resources that could be redirected towards longitudinal primary care, which we know is so foundational. So what we see is fewer people going into the kinds of care that we know our population really needs. And the reasons why are multifactorial, but they relate to an outdated payment model. So people not liking the fee-for-service system and not seeing how that's going to help them meet their own financial needs. It relates to not having the infrastructure and team-based support that they see that they would get, for example, if they chose to be a hospitalist. You work in a hospital setting, you automatically have a team, you don't have to pay rent or set up your practice. It also, though, goes back to the amount of pay and even the amount of respect that family doctors are afforded in the system. So often, even in medical school, you still hear that narrative, oh, you're just going to be a family doctor. Surely you can do better than that. So that kind of narrative really has an impact on people. And I think it is actually tied to the issue of pay, because when a profession is paid more relative to others or paid less relative to others, it confers how much respect that profession has. And so I think we have to fundamentally think about how well respected the job of the generalist is in medicine. And I think what's happened over the last decade or more is that there's been an increasing respect for specialization, when in fact, actually, I would argue that generalist medicine is increasingly difficult to practice because of the increasing complexity of patients, the increasing evidence base and whatnot. So I think we need to, as a profession, do a rethink about that and start to value family medicine as that foundation.
Tara, you're a wonderful advocate for family medicine. It's been an absolute pleasure talking to you, and thank you for sharing your insights.
Thank you.